Okay, good evening and welcome to this webinar, COVID-19 and Diabetes, Tackling the Challenge. My name's Alistair Lumb. I'm a consultant in diabetes in Oxford, and I've been involved with writing the guidance that Gerry Rayman is going to talk to you about this evening. We're very lucky to have Gerry with us this evening. So Gerry has done a huge amount of work over his career making inpatient care better and safer for people with diabetes. He most recently and most importantly for this webinar has set up the COVID-19 inpatient diabetes response group, which was convened to provide guidance for people looking after people with diabetes in the inpatient setting. I was lucky enough to be part of that group, which was incredibly sort of good to work with and hopefully productive, and produce some guidance which we hope people have found useful and that Gerry's going to present to us this evening. So I'll hand over to Gerry. Gerry, are you ready with your slides there?
Just a second.
Okay. Fine. Just I can tell you a little bit about the format of the webinar. So Gerry's kindly going to present some detail about the guidance that was drawn up. Please feel free to ask questions via the stage chat while Gerry's going along, and we can try and deal with those at the end. And then afterwards, both Gerry and I will be available, and we can talk about the process of developing the guidance and what has come out of that process.
So thank you, Alistair. I hope that you can see my screen now.
Yes. That looks brilliant.
Okay, I'm really sorry about that.
Myself away then. So I'll hand over to you, Gerry, and really look forward to hearing this.
Okay, so we'll keep this informal. We've already started in an informal way, so I'd like to thank Alistair for the introduction and for stepping in, because I should have started this, but I had difficulty getting my slides up. So as Alistair said, we're going to talk about how COVID-19 has affected people with diabetes and what we need to do to try and support better care for people with diabetes with COVID-19. So what have we learned so far? That's the first question. And what implications has this for us in terms of diabetes management? Well, I think one bit of good news is that there's no evidence that people with diabetes are at greater risk of being infected. However, they have a significantly greater mortality, and we all know that today. The evidence from the first 2 or 3 months showed that they had about a third of the deaths in hospital were from people with COVID who had diabetes. And this obviously affected type 2 diabetes greater than type 1 diabetes. 31% had type 2 diabetes, whereas a smaller proportion of the population has type 1 diabetes, and so 1.5% of those who were accounted for the diabetes deaths. Adjusted for age, sex, deprivation, and ethnicity and geographical region, the mortality in people with type 1, however, was even greater than type 2, 3.5-fold increase compared to twice-fold increase in people with type 2 diabetes. And this is shown reasonably well here on this slide, and you can see that in the red is the type 1 patients, the darker blue type 2 patients, and these are people with no diabetes. Ignore this one for the moment. But there are a couple of important things to see here. Not only is there an increased rate in people with type 1 diabetes, but age is a major factor. And you can see that this really takes off after about the age of 50. So our people with type 1 diabetes are very worried. We can be reassuring to them, the youngsters, the death rate in the youngsters, well, at the time of this study, on the age of 25, was 0. This really reflects exactly what I've said before, but it just shows you in a different way. You can see age and death rates here from the up to 39-year-olds compared to the 80-year-olds. So quite a marked effect of age. Type of diabetes here, as you see again, type 1 diabetes. Males were more likely to die, deprivation was an important factor, and ethnicity, again here you can see Asians and blacks and mixed races much higher than other races. In this particular piece of data, which came out from NHS England, Emma Barron and Jonathan Balabji, it was not possible to look at BMI from this data, but a subsequent study by Nabil Sattar shows that BMI is a significant risk factor. You can see the BMI going up here, and what is really important here is that you'll see that although I said males were more likely to die, obese females is not a very good thing. You can see the death rates in the obese females were really quite excessive. Preceding diabetes control, as reflected by HbA1c, again, it's been shown to increase mortality. What's really interesting is the early data from China, which showed that fasting blood sugar on admission, irrespective of whether or not you had a previous diagnosis of diabetes, was an important factor in terms of mortality at 28 days. And this is reflected in another study. This comes from the US, over 1,000 patients from 88 different hospitals. And they showed that people with diabetes or hyperglycemia, so admission hyperglycemia greater than 10, had a much greater mortality than those who were not hyperglycemic, so not diabetic or not having a high blood sugar on admission. I'll come to this in a slide in a minute, this bit down here. This is just showing you the same thing. People with diabetes or uncontrolled hyperglycemia at the beginning, 28% mortality compared to 6% in people who never had any high blood sugars. Well, I think this is a really fascinating slide. This is people who had diabetes or had an HbA1c on admission which was raised, so potentially undiagnosed diabetes. The mortality was 14.6% compared to the background population, which I said earlier was 6%. But look at this, people with stress hyperglycemia, people without a known diagnosis of diabetes, had a much greater mortality, 41%. And this really parallels something that we know from previous experience, that people with myocardial infarction, for example, if they have diabetes, their mortality is increased. But if they had no previous diagnosis of diabetes, but had stress hyperglycemia, they have a much higher mortality than even people with diabetes. And we see the same thing in people coming in acutely unwell for surgical emergencies. People with stress hyperglycemia and surgery are more likely to die than even those with diabetes. So, to summarize, we have persistent hyperglycemia associated with worse outcomes. And I think the bottom line for this is that poor glycemic control underlines the need for us to have specialist inpatients involved in looking after people with diabetes who go out of control. And so it was very disappointing at the beginning of the pandemic that all diabetes teams were more or less disbanded, and including the inpatient teams, and many people were just sent to do general nursing, for example, the diabetes inpatient specialist nurses. The doctors quite rightly had to do the acute medicine and so on, but actually our nursing staff were perhaps not appropriately used. So seeing that and getting feedback early on from the London network and also individuals in Birmingham who were part of the first wave of the pandemic, it was quite clear that something different was happening, and we needed to learn from that, and we needed to put together some guidance to help manage this problem. So in April, remember the pandemic started in the middle of March, so very rapidly we assembled a group of individuals, which we call the UK National Diabetes Inpatient COVID-19 Response Group. What was fascinating was fortuitously there were 19 individuals involved. These were specialists from the whole of the UK, so all 4 nations, Scotland, England, Ireland, and Wales, including national leads, not only physicians, but diabetes inpatient nurses, a pharmacist, and a psychologist. And we've now produced guidance on organisation of diabetes services, diabetes at the front door, the management of hyperglycemia, DKA, and so on. But I'll come to these guidances as we go along. So, as I said, we observed this from the London Diabetes Network and the Birmingham Group. What we did observe was an increased number of people with type 2 diabetes developing DKA, where DKA is relatively uncommon. We also saw an increase in new cases of diabetes, both type 1 and type 2. And the potential mechanisms involved here are severe insulin resistance associated with the cytokine storm, and also impaired insulin secretion from the beta cell. So this was early suggestions. Actually, the evidence now is that this is much stronger, that there is severe insulin resistance and impaired beta cell function. So put those two together, and it's not surprising that we're seeing DKA in people with type 1 diabetes from the infection itself, people with type 2 diabetes from not only the stress, the insulin resistance, but the impaired beta cell function. And as we know, SGLT2 inhibitors may increase this problem. And people who are not known to have diabetes, if you knock off their beta cell at any age, you can precipitate diabetes and even DKA. So our first bit of guidance was to warn people at the front door that breathlessness, which the knee-jerk reaction is this is COVID, but breathlessness could be due to DKA. So here is our first guidance, and this we termed guidance at the front door. Shortness of breath can be due to metabolic acidosis. All newly admitted patients should be evaluated for diabetes, a glucose measurement. If they're known to have diabetes, or if they have a high glucose, check for ketones to exclude DKA. Stop SGLT2 inhibitors. We initially said, and correctly, stop metformin in all patients, and then review the safety of continuing ACE inhibitors, ARBs, and non-steroidals. Now, subsequent to that first guidance, there's some really interesting observational studies which suggest, and I won't go through these in detail, but they suggest that mortality is actually reduced in people with COVID-19 treated with metformin. This is another study, I'll bypass that. But essentially, it's thought that what we have is that metformin activating AMP kinase, which causes downstream reduction in inflammatory cytokines, including TNF-alpha and IL-6. And there is some evidence to show that metformin lowers IL-6. This one study shows a lower IL-6, although not quite significant. The numbers were relatively small, but a reduction in CRP in those with COVID-19 treated with metformin, and a reduction in neutrophil leukocyte ratio, again suggesting that the inflammation is being ameliorated by metformin therapy. With regards to ACE inhibitors and statins, initially we were worried about this because of the ACE receptor, but actually the fact that the virus enters via their ACE receptor, but actually there was no evidence that they did any harm. If anything, they possibly were beneficial. So we've our subsequent guidance, our updated guidance said definitely restart the metformin, providing they haven't got lactic acidosis. So assess their lactate level, renal status, and hypoxic status. And with regards to ACE inhibitors and ARB, we've said they don't worsen the disease, but you need to use them in context with their, for example, renal function. This is an interesting study which suggests that DPP-4 inhibitors, and in this case sitagliptin, may be beneficial. You can see the sitagliptin treated patients had better outcomes. This may be related to the fact that they had better glycemic control. This is blood glucose here. You can see the glycemic control is better, but it may also be due, and it's been suggested, that it blocks the entry of the virus into the cells and it modulates the immune response. But this is one study, but there are other studies now looking at the potential benefits of sitagliptin. But until those report, I wouldn't suggest you rush out and use sitagliptin. So further into our guidance, obviously you do the blood glucose if they're hypoglycemic. This guidance was for generalists, those in the acute admission unit, and it just says follow your local guidelines for hypoglycemia. If the glucose is raised, then exclude DKA, and we gave them advice on the levels to action at, and then also consider why they might have developed DKA or become hypoglycemic. So, for example, sepsis or a broken insulin pen, and so on. Again, for generalists, we've given them the ketone levels at which to take action, and we've also advised if they're already on insulin, continue their basal insulins. If they're using wearable technology, there's guidance on what to do with that. And then finally, really importantly, exclude foot disease, particularly infection, which may be the cause of the sepsis and the ill patient. So that's the front door. What about managing the hyperglycemia? Well, the difference here compared to the usual guidance on managing hyperglycemia is that we're intervening at a glucose above 12, whereas most of us would intervene at 15 and in some places 17. But because of the evidence that I've shown you that above 10 is associated with an increased mortality, we're intervening much lower. Obviously exclude DKA. So what we're suggesting that people use corrective doses using rapid-acting analogs insulins, Novorapid or Apidra. And we've given some scales related to various factors. So if the patient has diabetes, type 1 diabetes, and know their correction ratios, there is a scale related to their correction ratio. So 1 unit reduces the blood sugar by 4. If that's the patient's correction ratio, there's a scale here for them. Whereas if the 1 unit reduces by 3, there's a scale here for them. If you don't know their correction ratios, then you can take their total dose of insulin, as shown here, 50, 50 to 100, and over 100. And if you don't have any of this information, so that you just take their weight. So newly diagnosed, for example, hyperglycemic patients, weight less than 50, 50 to 100, or greater than 100. So that's pretty simple, and it's been really helpful for those who know very little about what dose to start on. We've also got the maintenance with long-acting insulin, and we've given various types of insulin dependent on what's available in your hospital. And we suggest you start with 0.25 units per kilogram per day and titrate up. Of course, people who are older and frail or who have a reduced eGFR, we would suggest a slightly lower dose, starting dose. And then adjustment for this long-acting insulin, the maintenance insulin, is shown here for once daily long-acting or twice daily long-acting. And that's based on your fasting glucose values. And that's pretty straightforward, really. When the infection improves or enteral feeding is stopped or the steroids are stopped, obviously you're going to need to reduce the dose of insulin. Now, another piece of guidance which we'll skip through very quickly is this is for people who have DKA where you do not have an infusion pump. And at the very start of the pandemic, it was concerning that people felt that they would run out of the infusion pumps because they were used for very different reasons, such as the infusions of nitrates. We haven't had to use this in the UK. But it has been of value to people in third world countries. It's the usual aims for treatment. The only difference here is that we're now using subcutaneous insulin based on a 4-hourly regime. And I won't, as I say, I won't dwell on this, but it has been quite useful elsewhere. We've also had a slightly different fluid regime, but generally in the UK, we would be using the usual JBDS guidance. In the summer, we had the dexamethasone evidence and quite a number of papers to suggest that this was beneficial, and we had nice guidance on the use of dexamethasone, which is great, but we all know that dexamethasone can induce quite severe insulin resistance. We came out with some guidance and we updated that guidance. The important thing about this guidance is that this is for people with either dexamethasone or other glucocorticosteroids with and without diabetes. Now, you and I know about people without diabetes may become hyperglycemic, but not necessarily everyone. We had brought out an earlier version of this, but we soon realized that we actually needed much larger doses of insulin. The earlier version was based on the JBDS guidelines, where we had increased the amount of insulin to the, but this was an even greater increase in insulin. And some of you may have noticed that you're using several hundred units. And indeed, we have had patients on nearly 1,000 units of insulin. So just to recap, we know that glucocorticoids impair glucose metabolism, and certainly many of our non-diabetes colleagues do not know that this is the commonest cause of inpatient HHS. So we have COVID-19 related insulin resistance and impaired glucose metabolism. We have impaired insulin production from the beta cell, and now we hit them with corticosteroids impairing their glucose metabolism. So it's not surprising that many of these patients, even those without diabetes, are becoming quite significantly hyperglycemic. So that's a little bit of the background. So what are we going to do? Here's the glucose monitoring. But before I go on to glucose monitoring, one recommendation, which I think is really important, is that everyone started on dexamethasone or other steroids should have an HbA1c. Why? This will help differentiate stress hyperglycemia from previously undiagnosed diabetes. So if the HbA1c is normal, but the blood sugar is high, then they've got stress hyperglycemia or dexamethasone-induced hyperglycemia. Whereas if they're not known to have diabetes, but they have a high HbA1c, they have undiagnosed diabetes. And these two are really important when it comes to reducing your dose of insulin when the steroids are stopped, which I'll come to in a minute. The HbA1c will also give you an indication of the degree of insulin resistance and guidance as to how much insulin you might need at the onset. Our target glucose is between 6 and 10, and we're intervening at anything above 12. So up to 12 is acceptable. Frequency of monitoring is not a problem. It's 6 hourly, we all know that, but that is also for people who do not have a diagnosis of diabetes. If after the first 48 hours, these patients have not developed a high glucose, then you can reduce to once daily, usually in the afternoon, until the dexamethasone is stopped. So how are we going to manage the hyperglycemia? Well, first exclude DKA, which we talked about, using the usual checks, ketones, venous pH, bicarbonate. And we're going to use subcutaneous rapid-acting analog insulins. There's a very useful chart which is for both those with and without previous diagnosis of diabetes. And Alistair has done all of this work on these various algorithms. And again, we come back to, it's very similar to the previous hypoglycemic chart, but again, we use much higher doses of insulin. And again, we've got total daily dose of insulin or weight. So here we have a patient who's say 75 kilograms and they've got a blood sugar of 20, they would need 5 units. And you'll try that and you'll see how you get on, but 5 units may not be enough. And therefore, you might need to move up to another scale. So there's a possibility of moving between these scales, just as we do with our intravenous insulin infusion scales. If, of course, you're escalating up and you get stuck, you can go to variable rate intravenous infusion. But actually, many people have found this to be useful. And actually, when they move up the scales, they may realize that they need bigger doses. And there is a facility here for you to decide on your particular doses. Now, okay, you've corrected the hyperglycemia. You now want to maintain glucose control. And this is where you're going to need to put in a basal insulin at a dose of 0.3 units per kilogram per day. Now, this we recognize is quite conservative, and experience suggests that you may want to start at 0.5 units per kilogram per day, but many people are nervous but escalate up very quickly. We've suggested NPH twice daily. Now, you might ask why, because we know that dexamethasone has a long duration of activity of up to 36 hours. So why not use a much longer acting insulin? Well, the use of NPH, because it's twice daily, allows some flexibility. So you can increase the dose every 12 hours, whereas with the longer acting insulin, you need to increase it every 24 hours. So at the beginning, NPH may be really useful. And once you've established your dose, you may then move across to a much longer acting insulin. If the patient starts to eat, then you can introduce a bolus insulin. And some people will be well controlled on twice daily premixed insulins if they're eating twice a day or more. And again, we suggest that you be careful with the frail and those with a low GFR. If the patient is already on insulin, twice daily, basals, or twice daily premixed, we recommend that you increase the dose by 20 and as much as 40% of their original doses. And then we have the dose adjustment chart based on the fasting glucose levels. So, for example, 12 to 18 in the morning, on the once daily insulin, you'd increase by 10, and obviously greater if the blood sugar is higher. And in the twice daily, you'd base it on the morning and evening blood glucose levels. Once your steroids are stopped, then insulin resistance begins to fall, and that's what we've seen previously in people treated with dexamethasone. However, in patients with COVID-19, as they get better and the cytokine storm abates, then their insulin resistance falls very rapidly, and you may need to have a rapid de-escalation by as much as 50% in the first 24 hours. Of course, any dose changes should be guided by 6-hourly glucose monitoring. In people without a previous diagnosis of diabetes, and that will be guided by your normal HbA1c, they may need to come off insulin altogether. But remember, they may have an increased risk of later developing diabetes, and you need to alert their GP that they may need annual HbA1 screening. In people with known diabetes, but not previously treated with insulin, the HbA1c prior to the infection may guide in dose reduction. So those with a good HbA1c may be able to return to their pre-illness medications, whereas those with a high HbA1c may need to continue on additional therapy. And discharge and follow-up are obviously important. There's an increased risk of patients becoming hypoglycemic if the de-escalation is not supported, both in people with steroid-induced diabetes and people with known diabetes. So in summary, exclude diabetes in all admissions. If known diabetes or new hyperglycemia, exclude DKA. Think DKA if they're breathless. Atypical presentations are not uncommon, a mixed DKA and HHS. These patients are often very insulin resistant and exacerbated by corticosteroids, and on recovery, insulin requirements may fall dramatically. All the guidance is available on ABCD and Diabetes websites, Diabetes UK websites. So I'm going to stop there and hand it over to yourselves to ask questions, and for Alistair and I to field the questions. Thank you.
Thank you very much, Gerry. That was incredibly clear and a lovely description both of the impact of COVID-19 on, you know, our inpatient population and the impact in particular in terms of diabetes. There aren't particular questions appearing yet in the chat. Please do use the stage chat for any questions that you have, and we'll keep a close eye on that. If it's all right, was going to kick off with a question for you, Gerry, which is a slightly loaded question, having been involved in some of this, but you've been involved in inpatient diabetes care, you know, for many years now, and have really been leading the way in that. How different did you find responding to COVID-19 and responding to the pandemic compared with your previous experience of inpatient diabetes work?
Yeah, I have to say, I mean, I know COVID is a terrible thing, but actually it has really stimulated the diabetes communities to come together to produce something very rapidly. I've been involved in JBDS and other guidance and other national initiatives which move quite slowly, but this moved incredibly rapidly. Not only did we get the guidance, we got publications out within weeks of the guidance being formulated, and the guidance has been taken up not only in the UK, but it's actually received global recognition, and as I've said before, for example, the subcutaneous insulin for DKA guidance has been welcomed, and indeed the president, one of the presidents of the ADA, actually referred to these guidance in one of the global talks that he gave. But yeah, I mean, it's been great. The group has been incredibly productive, and we haven't stopped, as you know. So you, Alistair, have been really instrumental in a lot of the stuff that we've done. And we are now, and with Alistair leading this, we're now producing guidance for what happens in virtual wards, because dexamethasone will continue to be used in virtual wards, and they'll be needing to be monitored on those virtual wards, as well as step down from the virtual wards. And I think there's a lot more we need to do in terms of step down from dexamethasone when people go out into the community.
Thank you. We have a question from Laura O'Donnell, which is particularly around the dexamethasone guidance. And I know this is something that we discussed a lot at the time. So the JBDS guidance for steroid-induced hypoglycemia, the first line is gliclazide, but Laura points out that the ABCD guidance doesn't recommend gliclazide first line for dexamethasone-induced hypoglycemia. And the question is, would it be feasible to use this to reduce injection burden?
Okay, that's a really good question. And one of our colleagues was really concerned that he was seeing a lot of patients who needed to go onto dexamethasone and potentially needed insulin, and they hadn't got enough inpatient diabetes nurses because within his hospital, the inpatient nurses were dispersed to general nursing. So he felt that potentially putting all these patients on insulin was dangerous, and could he not use glycoside? And the answer to that is absolutely. This is guidance. This is not the law. You can do what you think is appropriate at the time. But the feedback from most people is that it doesn't work. And the reason it doesn't work is that if beta cell function is impaired, glycoside works through increasing the secretion of insulin from the beta cell. So maybe if it's not that impaired, the beta cell function, glycoside would work, but the experience is that it doesn't.
Yeah, I think certainly, our experience locally, and very much what we heard from London and Birmingham, and I have to say that London and Birmingham led the way in terms of a lot of the learning that was used to drive this guidance. Was as you've said, I think we've all been very happy for people to try it, but actually the majority of people who have been affected by the hypoglycemia, glycoside has been insufficient to manage them. I think those with milder COVID-19 disease, then absolutely, but often those people weren't ill enough to warrant steroid treatment. So actually, in order to warrant steroid treatment, you had someone who already had fairly severe disease, which was leading to a degree of hypoxia. So I think that's in the end why we came down on the side of insulin for the main guidance. But it's absolutely a reasonable suggestion.
I'd be interested to hear. Unfortunately, I can't see the chat, but I'm going to put this out to the audience. Are people? I mean, we have had people receiving hundreds of units of insulin. Is that experience from those within the audience? I mean, as I said, we've had one patient receiving nearly 1,000 units of insulin, and that seemed to coincide very much with those who have been receiving enteral feeding. I don't know if that's your experience, Alistair, that enteral feeding is a factor here. Yeah,
there's enteral feeding has certainly had quite a strong influence, and in those high dependency and intensive care environments where it has historically been the standard of care. But I think it's also the massive insulin resistance in terms of, particularly associated with the steroids. And we were discussing someone last week who was up to 10 units an hour on a variable rate without a previous diagnosis of diabetes whilst on steroids, and the insulin treatment stopped immediately, pretty much, in that individual when they came off the steroids. That coincided with them being much better and being out of an intensive care environment as well. But actually, you're going from 200 and something units a day to nothing, but it's 0 to 240 to 0, which is very much a new experience. There's a couple of really lovely questions here. So there's a comment from Gemma Wilkinson who has said, we found people have required large doses of insulin on variable rate and been commencing long-acting insulin alongside variable rate, and was wondering whether other people have had to do that as well. And I think
that's been standard for us. We've done that.
Yeah, I mean, absolutely agree. It's been standard for us, and that was very much because we were listening very closely to the London experience, and they found that very quickly that actually they were needing because people were needing a lot of insulin per hour, they were needing to layer background insulin on top just in order to be able to try and manage things.
Yeah, Natalie's put something interesting in here, and that's absolutely right. So she's found people needing a lot of insulin on their admission with illness, and later they've been found to have COVID. And she's alerted the ward staff that actually, if you find someone needing a lot of insulin, think that they may have COVID. And I think that's certainly our experience.
Yeah, I think that's a really good tip. And D. Mossaher has said in our ITU, double strength act rapid in the variable rate is being used in some people, which I think is, entirely real. And Sally Lovers has commented that enteral feeding and proning is causing me a headache, and I think that is absolutely true for all of us. I
think an arm ache as well.
Yes. We I think fortunately have military personnel coming in to help now with that sort of thing, who are much fitter than the rest of us.
Yeah.
Claire Hankey's, I think this is a really interesting question actually, saying we have found the number of newly diagnosed people with type 2 has been very high. Do you think primary care is going to find this overwhelming, as we don't have the capacity to follow them up in secondary care?
So that is a really good point, and this is where we're working with the London group about how we can't just dump these patients out of hospital into primary care and leave it at that. We need primary and secondary care linked up in some way, and so we need good guidance on discharge. And the London group has put together some guidance which will help with that. And Alistair and the COVID-19 group are taking that guidance and refining it for more national use. What happens to these patients after they get over their COVID or their dexamethasone is actually quite complex. There are multiple different scenarios, and so what we thought was going to be a rather easy discharge guidance is becoming quite tough to formulate, but we will be doing that in the next couple of weeks.
Comment from Lilith Legister has said rapid access clinic helps here. So it may be a model. I mean, I think that's a really interesting model, the rapid access clinic. It's certainly very useful. I think that there have been a couple of challenges to that locally in the short term. I think it may be longer term, the way that we go, certainly even with the recognition that we need to maintain diabetes services, and we're lucky being a large hospital, so we have a relatively large team, but we actually lost 3 whole-time equivalent diabetes nurses to all of whom had intensive care experience, to newly convened HDU environments. So our non-invasive ventilation beds went from 8 to 60 over a period of about 3 weeks recently. So yeah, I think rapid access clinics where the staffing allows is a really good idea. But I think it is, as you've said, Gerry, it's something that we're going to need to be able to build guidance for as much as possible, because I don't think there's capacity in primary care or secondary care at the moment.
Yeah. I do hope. I mean, we're in this second wave or third wave or whatever it is, and we do have a large burden, but it seems to be turning the corner. And so just as we didn't need all the subcutaneous insulin for DKA, I hope that the guidance that we're writing for the COVID virtual wards may have short time life, but I don't really know.
Yeah. I mean, actually, I've never spent so much time on something I hoped that we wouldn't need when we were writing the guidance for using subcutaneous insulin to manage DKA and HHS. I'm really glad it has proved useful actually in sort of less resource-rich environments. But we were really praying that we didn't need to use it in the UK, because that meant that essentially hospitals were running out of infusion pumps, and that's not a situation we want any hospital to be in.
So one of the things that happened to us a couple of weeks ago, when we were using, we had quite a few patients on hundreds of units of insulin and thousands, almost on 1,000, and we were running out of insulin. So we had to alert pharmacy and make sure that the insulin supplies were being maintained. I don't know if anyone else had a situation like that. So, Alistair, there's a question here from Susan Tutty.
Yeah.
What's your opinion on stopping metformin when requiring oxygen?
Yeah.
They're confusing on when to restart. So, presumably they're going to be hypoxic on oxygen. Is metformin contraindicated?
Yeah, I think that's a really, really good question, because I think metformin is one of the things that we were very nervous of early on, with the evidence around concerns around lactate, and also we have seen people with quite profound renal impairment early on with COVID as well. So hypoxemia we felt would predispose to lactate production, and also be concerned with renal function tailing off and not being able to excrete the metformin. I think the data around metformin potentially being protective have probably changed my view on this. I have to say that if people have a kind of treated hypoxemia, so they have an oxygen requirement, but they're maintaining adequate oxygenation, then I think I'm now of the opinion that I would continue metformin in that group. I don't know how you feel about that, Gerry.
I do. I think, to be honest, lactic acidosis is overblown. I mean, I've only seen one true case of lactic acidosis related to metformin, and that's when a GP gave 3 times the dose, maximum dose, and that patient ended up in the ITU really very unwell. Most of the other cases I've seen have been people with sepsis and so on, and it's probably the sepsis, not metformin. But the fact that they've been on metformin, people have kind of said metformin is to blame, but I doubt it.
I would agree with that. I mean, you actually see it, and certainly in UK hospital populations, you see genuine metformin-induced lactic acidosis extremely rarely.
Yeah. I'm really pleased, Claire, has put up, Claire Henke, that the guidelines have been useful and they're glued to the wall. That's great, because that's what we've worked hard to do, and I think generally people have really welcomed these guidelines. One of the disappointments was that the guidelines have not been widely distributed. They sit on the ABCD and Diabetes UK websites, and I did a webinar to the East of England respiratory physicians last week, and they'd not heard about them, and they were really quite stunned, and they thought the guidelines were really useful. And over the weekend, several of them were using them, and had written to me on the Monday to say how valuable the dexamethasone guidance had been. And subsequently, I don't know who it is, but has been in touch with NHS England and said, why have these guidelines not been distributed? And I had an email today from NHS England to say that they were going to make these guidelines available. Now, one of the difficulties that Jonathan and Partner have with NHS England is that they're very reluctant to bombard people with guidelines and so on, and you can understand that. But I think the value of these guidelines have been shown to be very appreciated by others. So I'm pleased to say that it'll get more widespread use or exposure.
Yeah, and I think Diabetes UK who've been incredibly supportive in terms of the development of the guidelines. So they have been using their local networks, and they've got sort of local clinical networks to disseminate the guidance as well. There's a comment I wanted to pick up on from Sally Love, who said locally that GPs seem slightly unaware of the situation. I think this is in terms of the impending wave of people who've had either COVID-induced or steroid-induced hypoglycemia, and only had 2 attending a discussion recently to address follow-up. Is that common? I think that's a really, really interesting question. Gerry, has it been sort of locally for you in terms of input from primary care?
Well, it's a very variable picture. And forget the guideline, forget the discharge into the community, just the care of people in the community with diabetes. Some GPs have kind of shut up shop early in the pandemic, and we have fielded thousands of calls from patients who are not our patients who have needed advice. Some GPs have continued to do annual reviews, for example, which is fantastic, and they've really engaged with their patients. I recently did a very short 5-minute slideshow with voiceover, which we text out to our 3,000 patients with diabetes to say how we were running our clinics in the future, and that they'll be virtual and that sort of thing, and that if they are going into primary care for anything, could they ask for their feet to be checked and their blood pressure to be measured? It seemed a sensible thing to me. And is it possible for them to do that? That was only a question. And I got flack back from primary care that we were offloading on them, which is a bit disappointing when we've kind of done so much to try and support. So you've got really good engaged primary care, and you've got primary care which may or may not be as engaged.
I think we've had a similar thing locally, but I think one of the things that very much recognised is the amount of pressure that primary care has been under, and actually recently the incredible work that they've been doing with the vaccinations. I wanted to pick up on, there was something from Laura O'Donnell here. So previously or recently have had people with no previous diabetes having hypos, even as soon as the steroid treatment stops, or even on the final day of dexamethasone treatment, which seemed to be related to clinical improvement. And just, I think, wondering whether other people had a similar experience. Gerry, have you come across?
Yeah, I mean, if they're maintained on insulin, then that is definitely a possibility. But I presume she's referring to people in whom the steroids and the insulin has been stopped, and maybe because we're using longer acting insulins, maybe there's a degree of absorption from the various sites still. Which is protracted over several days. So I could understand that as a possibility. But, the picture is so very, I mean, we've had people who've come in who are on insulin, certain dose of insulin in the community, and we've put them on dexamethasone, and they've needed much less insulin, which I often say to my patients, we are not machines. We're humans, and we all react differently in different ways. So that's why a guideline is a guideline. It is not gospel.
Absolutely. So I think a challenge here from Corinna Riley: could there be a clearer decree? I'm not sure we're capable of decrees. Read metformin. Saying that they're locally advising stopping metformin in all people with COVID-19 and then reassessing for recommencement with a lactate check at discharge. I mean, I think, the front door guidance has got a little bit of, and we deliberately updated that actually as the data was adjusting on metformin. So it has got a little bit of guidance on that, but it's not particularly prescriptive. So we can certainly look at that and take that back to the group, I think. Yeah. Comment from Natalie Flood. I think, the experience of people with who are dealing with inpatients with diabetes. Said she's dealing with an increase of diabetes secondary to alcohol excess and increased admissions in young people with type 1. So self-neglect and increased need for psychological support due to the burden of the pandemic. And I think there has been quite a lot, certainly our experience in the first wave very much. Now we focused a lot of our attentions on people who perhaps are admitted more frequently, or people with high HbA1cs, was where we had limited sort of outpatient and inpatient capacity, but we were focusing on managing people who are inpatients and trying to prevent the need for admission in that group. And actually, our local experience in the first wave was that we saw fewer of the younger people with type 1, that they were opting, feeling more able to self-manage. And I think feeling more able because they didn't want to be in hospital. It was a different environment from the one that they were used for, and actually they were more scared of it. Not sure that we've seen that so much in the second wave, actually.
I think the interesting data is from Shivani Mishra at Imperial St. Mary's, was that the frequency of admissions for DKA for type 1s fell, but then they were seeing type 2s with DKA, which is what we kind of saw around the group. So although DKA admissions didn't increase overall, the two different groups behaved in a different way.
Practical question from Jane Walker. How are other people prescribing the variable insulin doses for hypoglycemia on treatment charts? Well,
the charts I've shown you there, we've reproduced and we've put them on the wards, and they've used those charts as they are.
Yeah, we have electronic prescribing, which, and again, the electronic prescribing team have been really inundated with requests all the way through the pandemic. So we've actually prescribe the short-acting insulin as a variety of doses, and then ask people to refer to the guidance. So we've been using the guidance essentially as the way of doing that. I'm not sure that necessarily answers the question on specific treatment charts, but I think sometimes, certainly previously we've attached essentially the guidance to the treatment chart, and said as per attached guidance, something like that. It depends whether you're using paper charts or electronic charts as well.
So Sally has suggested that that they are seeing hypos in the last couple of days of DEX. I presume the incidence continued, and she said, she's assumed that this is because of clinical improvement, and I would agree with that. So as the cytokine storm abates and the insulin resistance falls, even though the dexamethasone hasn't been stopped, you've taken away some of the insulin resistance. And if you're continuing on high dose insulin, then there's an increased risk of hypo. So I would agree with her on that.
Yeah, and I think it's been one of the confusing things about because when people, certainly in the second wave, we've seen people improving much more quickly. So in the first wave, I think people's clinical dip was deeper and it took longer for them to come back up. And what we found with dexamethasone is that people don't deteriorate as much, and that the overall time period of the deterioration is shorter. And so, as Sally's sort of alluded to, that actually you come to the end of the 10-day course with dexamethasone and actually people are improving really significantly clinically compared to when they were started and when they came into hospital.
Yeah. So Alistair, Leicester asks, how can we get the CCG to prescribe Toujeo, which works very well on basal bolus due to COVID, having to complete a transfer of care document? I don't know. I haven't been involved in this.
We have Toujeo already on our local formulary for recommended. So I think it is quite hard. I mean, the only thing I can recommend is most CCGs, certainly our area prescribing committee, are still meeting, but are very much focused on things associated with COVID. You know, that's what they're doing. So you may be able to sort of take the argument that this is a COVID specific requirement. I think Sally's comment there, which if you're, you know, one of the things with Toujeo, with the longer duration of action, and one of the reasons that we actually went with MPH insulin in terms of rapid up titration and down titration around the changes. So it can be challenging, but certainly if you're having success with it, I think it's an early conversation with medicines management in your local CCG.
So we're 5 minutes over our time, and I've really enjoyed the questions. They've been great, and I very much hope you all enjoyed this session. And thank you very much, Alistair, for fielding the questions with me and standing in at the beginning and really chairing the questions. I'd like to also thank the group at Orange Juice Communications who put this together. And this has been the first of our webinars for the Diabetes Inpatient Forum. I really hope you've enjoyed it, and we will be doing further work on the forum. There's a lot more that we can discuss in the future, and we'd be really interested in any things that you would like to discuss on the forum. So thank you. Alistair, would you like to close?
Yeah, well, I think really just to say thank you very much to you, Gerry, for a real tour de force. So what you gave us was a lovely summary of what we've learned about COVID, how it affects people both with and without diabetes, in terms of the metabolism and glucose management, and also the process that we went through in terms of developing some guidance. And we're really, really glad to hear that people have found the guidance interesting and useful at times. So yeah, thank you very much, Gerry, and thanks everyone for taking part.
Yeah, thank you. And you know, one of the things that it has brought out, despite the COVID group that we've got together has been great, but actually the whole diabetes community has come together. So all the best to you all. I think people working in diabetes are really interactive and very patient-centered. Good night, everyone.
Good night. Thank you.